Hello, this is Kim Jong-il. Today's lecture will be on the double arch wires and the intrusion arch. We treat cases of deep overbite by intruding the incisor or extruding the molar. When we intrude the incisor, we use the term bite opening. When we extrude the molar, we use the term bite raising. When we intrude the incisor, we may intrude either the maxillary or the mandibular incisors. We can use the intrusion arch for non-extraction treatment. The methods of obtaining space are as follows: incisor labioversion, occlusal plane change, mandibular forward movement, and lower incisors uprighting. The first method of obtaining space is incisor labioversion. There is deep overbite, and the incisor is in lingoversion. In this case, by performing incisor labioversion to a normal angle, we obtain space. The second method is adjusting the occlusal plane. Dr. Brown mentioned that dental occlusion is closely related to the changes in the inclination of the occlusal plane. 1-degree change on the occlusal plane is said to bring 0.5 mm of change on the dental-occlusal relationship. The UOP is 16 degrees. It is steep UOP. In comparison to a normal UOP of 10 degrees, it is steep by 6 degrees. If we change the UOP of 16 degrees to the normal value of 10 degrees, we can cause 3 of change on the dental-occlusal relationship. The third method is mandibular forward movement and lower incisors uprighting. When the maxillary molars are extruded by using the intrusion arch of the maxilla, the mandible may move forward. What happens when the mandible moves forward? The mandibular incisors are lingually uprighted. Then, regardless of crowding in the mandibular anterior region, we could resolve crowding without moving the mandibular incisors. At this time, the position of the maxillary incisor is clinically important. Generally, the maxillary anterior teeth should be located 3 mm below the lip line. Let's look at the appropriate conditions to perform intrusion and its indications. Firstly, a large incisor to stomion distance. This is the distance from the U1 to the lip line. It is normally 3 mm, but if it's over 5 mm, intrusion is required in the maxillary incisors. Secondly, a large interlabial gap. The gap between the upper and lower lip is called the interlabial gap. This is also normally 3 mm. If it's over 3 mm, it is called a large interlabial gap. How should we treat a large interlabial gap? The maxillary incisors should be intruded, or the upper lip should be extended. If the interlabial gap is bigger than 3 mm, we must determine whether the problem is the upper lip or the over-eruption of the maxillary incisors. Thirdly, a high lower lip line. The top of the lower lip is usually located at the incisal 1-3 of the maxillary incisor. When the top of the lower lip is located near the incisal edge, we use the term low lower lip position. When it is located in the CEJ area of the maxillary incisor, we use the term high lip line. The lower lip position is very important clinically. We must therefore check the relationship between the lower lip and the maxillary central incisor. For cases of Class II Division I, the lower lip will be positioned lower, and for cases of Class II Division II, higher, and we can observe the maxillary incisor going through linguoversion and extrusion. In this case, intrusion of the maxillary incisors is required. As such, I check the relationship between the lower lip and the maxillary central incisor. Usually the lower lip should be located at the incisal third. I prefer the top of the lower lip to be located more towards the incisor than the archwire. Let's look at this patient. The dental probe is mainly used to check the relationship between the lower lip and the maxillary central incisor. Currently, the lower lip line is located more gingivally than the maxillary central incisor CEJ. The ideal lower lip line is at the incisal 1-3, like this. Here, this patient's U1 to lip line is 10 mm. Supra-erupted maxillary incisors should be intruded, but it's limited. For us to evaluate whether or not the intrusion of the maxillary incisor is necessary, we must not only check the Ceph analysis but also the clinical relationship between the lower lip and the maxillary incisors. Fourthly, a short upper lip. When the distance from the base of the nose to the lower part of the upper lip is less than 21 mm, we use the term short lip length. In this case, intrusion of the maxillary incisors and lip training are required. Fifthly, a high gingival smile line. A gummy smile is unaesthetic. We may need intrusion of maxillary incisors. Sixthly, a large lower anterior facial height. There may be cases with a long lower anterior facial height and a gummy smile, requiring intrusion of the maxillary incisors. The left is a case with a short lower anterior facial height. How would the face be shaped with the case on the right with a large lower facial height? Round or long faces? The answer is long. To review, there are 6 indications that require intrusion. 1. Large incisor to stomion distance. Large interlabial gap. 3. High lower lip line. Short upper lip. 5. High gingival smile line. 6. Large lower anterior facial height. In this case, maxillary incisors intrusion is required. Patients with these cases may have long faces or round faces. Differential diagnosis for intrusion is made through Ceph and clinical evaluation. For Ceph evaluation, we first check the U1 to lip line. If the U1 to lip line is over 5 mm, intrusion of the maxillary incisors should be considered. We then check the UOP. For cases of steep UOP over 15 degrees, intrusion of the maxillary incisors should be considered. For clinical evaluation, we check the relationship between the lower lip line and the maxillary central incisor. The high lip line is a case when the top of the lower lip is located on the gingival third of the maxillary central incisor. In this case, intrusion of the maxillary incisors is required. Intrusion of the maxillary incisors is also required when the interlabial gap is over 3 mm. Intrusion can be classified into the following 3 categories. The first is true intrusion, when the incisor is actually intruded. The second is relative intrusion, which is when the anterior region appears to be intruded due to the extrusion of the molars. The third is pseudo-intrusion, which looks like intrusion due to the labioversion labial tipping of the maxillary and mandibular incisors, but is not. There are 2 methods for intrusion. We can either use an intrusion arch or a mini screw. The intrusion arch consists of a utility arch wire, which should be directly engaged on the bracket, and a two-piece double arch wires. The mini screw can be positioned between the maxillary central incisors or between the maxillary lateral incisors and canines. The biggest problem with intrusion is that force is directed on the root apex. Therefore, the roots are likely to be resorbed. To prevent this, a weaker orthodontic force should be applied compared to that of other tooth movements. The principle of intrusion is that we should use as little force as possible. The intrusion rate does not increase with stronger force. What does increase is root resorption and the side effects of the anchorage unit. So we must apply as little force as possible. Normally, 60 to 80 grams of force is recommended for the intrusion of 4 maxillary incisors. Remember that the load deflection rate should be low because the force is well sustained. Dr. Burstone outlined the following 6 principles for intrusion in 1977. 1. A consistent weak force with a low LDR should be applied. 2. Only a single point should contact the anterior. 3. The point of force application must be carefully selected, considering the center of resistance of the tooth. 4. Intrusion can be selected depending on the incisal dentition. 5 and 6. The reactive units must be adjusted, especially avoid being extruded. We need to think carefully about principles 5 and 6. The side effects of intrusion are extrusion of molars, palatal inclination, and distal angulation. Many people use high-pull headgears or mini screws to prevent extrusion and TPA to prevent palatal inclination. Many also reinforce anchorage to prevent distal angulation. However, for normal growth in mio-orthodontics, the maxillary tooth neurosix must be extruded. A counterclockwise force must be applied. On the occlusal plane, the maxillary first molar must be extruded, and the maxillary incisor intruded. Therefore, the extrusion of the maxillary first molar is good. TPA is not necessary for patients with high angle and lip seal. And the same could be said with patients with low angle. This is because the extrusion of the maxillary molars is necessary for the mandible to protrude forward. One of the biggest side effects of intrusion is root resorption. Many authors claim that maxillary anterior root resorption is inevitable during intrusion. The greater the amount of intrusion in the maxillary anterior region, the greater the amount of root resorption. Recently, mini screws are also occasionally used for intrusion. We can place one mini screw between maxillary tooth number 1 and number 1, or 2 mini screws between the maxillary tooth number 2 and number 3 for both sides of the maxilla. When placing 2 mini screws on both sides of the maxilla, the location of the left and right mini screws depends on the attached gingiva. What would the consequences be? The force levels on the mini screws are inevitably different. Therefore, one side will become more intruded than the other. Please keep this in mind when using the mini screw. This difference in vertical dimension can cause canting on the occlusal plane. This can create yet another malocclusion. I determine whether to intrude the incisor or extrude the molar by evaluating the U1 to lip line and the UOP. What should we do when the UOP is bigger than 15 degrees? We can intrude the maxillary incisor without touching the maxillary molar like case A. Or we can perform intrusion while also performing extrusion on the maxillary molar like case B. The UOP would be flattened at case B. The incisors would also be less intruded compared to case A. The extrusion of the maxillary molars allows the mandible to grow forward. We may get desirable results for cases of class 2 malocclusion and deep bite. As shown in case C, only the maxillary molar can be extruded without moving the maxillary incisor. We can use the headgear to do this. We must decide the direction of treatment by determining if the patient is a high-angle type or a low-angle type through skeletal analysis, and also considering the anterior relationship, overjet and overbite. To flatten steep UOP, as shown in case B, I recommend slight intrusion of the maxillary incisor and slight extrusion of the maxillary molars. Please remember that greater intrusion results in greater root resorption. In addition, the angle of the maxillary and mandibular incisors must be considered during intrusion. Unlike cases with proper root torque, cases of insufficient lingual root torque require a counterclockwise force. What would happen if clockwise force is applied like in case B? The bite will be deeper and the maxillary incisor will be further extruded. On the other hand, a counterclockwise force like in case A is good for overbite and does not disturb a normal growth and development pattern. If intrusion is necessary, we must evaluate the U1 to lip line, the UOP, the U1 to FH angle, and the interincisal angle. This is a case of steep UOP. We must decide whether to perform intrusion first or anterior strategic leveling first. For strategic leveling, we can use an open coil spring around tooth number 3. What will happen to the anterior region? It will protrude forward. This would result in pseudo-intrusion as such. It is recommended to correct the maxillary incisal axis angle through careful analysis of crowding and the U1 to FH angle before performing intrusion. Cases A, B, and C are different even after intrusion. If the point of force application is positioned backwards, as in case C, the anterior crown would experience lingual tipping. For cases of Class 2 Division 1, treatment would look like case C. For cases of Class 2 Division 2, it would look like A, and for true intrusion, like B. We can bend the hook of the anterior segment arch wire depending on the type of intrusion we want. This intrusion arch has the following advantages. 1. Intrusion of the incisors. Deep bite correction. 3. Better aesthetics. On the other hand, a disadvantage of the intrusion arch is root resorption. Many argue that the second disadvantage would be the extrusion or the tipping of the molars. However, we can get satisfactory results if normal growth and development is taken into consideration. Differential diagnosis for intrusion of upper incisors is performed through CEPH and clinical evaluation. If a patient has a longer U1 to lip line than 5 mm and a steep UOP of over 15 degrees in CEPH evaluation, intrusion of the maxillary incisors is necessary. If a patient has a high lip line or a greater interlabial gap than 3 mm, intrusion of the maxillary incisors is also necessary. Thank you for watching.